36-year-old man with known HIV infection comes to the emergency department because of a 2-week history of malaise, so just generally feeling unwell, and non-productive cough. He has not been compliant with his HIV medications. He denies any illicit drug abuse, and he has never been hospitalized in the past. So not being compliant with your HIV medications is a very big thing. I mean, you always want to make sure that patients are being followed up with in the ID clinic, especially after a new diagnosis of HIV. The big thing is that non-detectable means non-transmissible. So, in order to control things like spread and outbreaks, like you want to make sure that these patients are actively taking their antiretroviral therapy. And I will say, like, a lot of infectious disease doctors that work in that clinic setting, like, do everything they can to get these patients these honestly very expensive medications. And their social workers probably do a bunch too, because medications like Amtriva, name some other ones. It begins with a D. Descovy, right? Like these drugs, highly active antiretroviral therapy. Like these drugs do so much in preventing the HIV virus from replicating inside somebody and controlling the spread of HIV from a patient and their partners, that like if you do not, or if you just let the patient like slip through the cracks and you don't follow up with them and suddenly the viral load comes back in like the hundreds of thousands or the millions, like that is actually a very bad thing. Not just, from like a personal perspective where, yeah, their CD4 count is probably going to tank and they're opening themselves up to a lot of different opportunistic infections, but also just like on a public health level too. His temperature is 102. Okay, that's pretty bad. Blood pressure is 122/70 and pulse is 112 a minute. So he is sick. His O2 is 90% on room air. So not terrible, but not great. His BMI is 23. His SCM muscles are prominent bilaterally with each respiration. Cardiac exam reveals tachy without any murmurs. Scattered rhonchi are heard on lung auscultations, and his abdominal exam is within normal limits. All right. So he's got a low white count, but in the context of infection, in the context of somebody with HIV, probably normal. Low platelets, creatinine, okay, sodium is fine, potassium's a touch high, glucose is okay, calcium's fine. Chest x-ray shows bilateral patchy interstitial infiltrates. IV fluids and high-dose IV Bactrim are started. The patient should be specifically monitored for which of the following. Okay, well, this is just like a first-year med student question. All right, so this has nothing to do with HIV. This patient probably has a terrible CD4 count below 200 that makes them susceptible to PCP pneumonia or PJP pneumonia, pneumocystis jirovecii pneumonia, which is where they're getting this bilateral patchy interstitial infiltrates from. Like I said earlier about opportunistic infections, there is like a whole host of infections that you can only get when your CD4 count is, less than 200, less than 100, less than 50. You're thinking things like toxoplasmosis, cryptococcus, I don't know, disseminated candidiasis. Like there are only like certain things that you think of like about that. So bilateral patchy interstitial infiltrates, like you were thinking PJP pneumonia. He started on IV Bactrim, and so if you've ever been in a hospital that you get to round with a pharmacist as part of your rounds, they will talk about how Bactrim causes a type 4 RTA, a type 4 renal tubular acidosis, which causes hyperkalemia. Don't ask me the mechanism of that. This is just a random thing I remember getting pimped on in residency, and this is the correct answer. I don't know how to apply this to my clinical practice at all. I mean, it's just like, okay, give them Lokelma, give them Florinef. I'm surprised this is on boards. Like, this is like a step 1, step 2 question. Yeah.
We get like routine labs all the time anyways for people in the hospital, so I think it's a little bit moot, but like in practical senses, you're going to find out anyways. But I guess it's trying to say, don't forget that Bactrim can cause problems, and this is what you need to watch out for.
Distal tubular epithelial cells, yeah. So this is a type 4 renal tubular acidosis. I mean, there's not even like a teaching point here. It's just, it is what it is.
45-year-old woman comes to the physician because of frequent urination for the last 6 months. She states that she has been waking up several times at night to urinate. These symptoms also disrupt her professional work schedule. She's been taking lithium to treat mood disorder for the past 5 years. She has tried many other drugs for her mood disorder, but none have been as successful as lithium, so unfortunately she has to take it.
She has to be on lithium.
Yeah. She's adherent to her treatment and has her lithium level measured regularly. She has one episode of mild lithium toxicity 2 years ago. Her physical exam is fine, and here are the labs. All right, kidney function's not doing so great. And then the urinalysis, we got trace protein, but everything else looks normal. Right?
Ooh.
Oh, there it is. There it is. Water deprivation test. I mean, the answer here, this is like a step one question. It's like very pathognomonic for what we're going through. Lithium causing people to diurese a lot, to urinate a lot. It's very specific. It is nephrogenic diabetes insipidus, which for people who don't know what that means, it means absolutely nothing. But what basically happens is that the lithium messes with the kidney cells that are supposed to be responsible for reabsorbing water, right? Because of that, your kidneys dump water. They just dump water. They don't respond to your body's natural feedback mechanisms in order to tell it to stop dumping water and to reabsorb the water back into the body. So you just pee constantly, and it doesn't matter how much you drink. If you stop drinking, or if you do drinking, if you are drinking water, the medicine, the lithium, is causing problems. But the problem is that it's not the only thing that can cause this diabetes insipidus, right? There's also what happens if your brain stops telling your kidneys, hey, please reabsorb the water. So your kidneys think, oh, I should just dump all the water then, right? That's called central diabetes insipidus. And that's because the brain's not doing the job versus the kidney not doing its job.
We have urine osms of 300 at baseline. And then after you give desmopressin, which is an arginine mimetic, I think. So it does what vasopressin would normally do. It did not really change the osms, or like it's slightly. I can't. Wait, is 325 significant from 300? Like I don't even know actually.
No, it's not.
So it's unchanged, right? So it's not responsive to DDAVP because it's not nephrogenic DI.
Okay, here we go. I got it. I have to remind myself. By the way, this is the issue with being an attending doctor is that we have access to look up resources now, unlike students or residents where you have to memorize stuff for tests. So, we kind of dumped all the stuff from our brains immediately after we took this test because we're like, we can just look it up if we need to remind ourselves of a particular mechanism, right? We're gonna get the right answer because we know what it is.
We know what it is. I just don't know how it is.
Right, the mechanism, like the nitty-gritty details, which, ultimately, do the patients care if you can explain them the mechanisms or not, or do they care if you get the right treatment for them and they feel better? People aren't wrong, we should still know this. So long story short, after having to remind myself about this, DDAP or desmopressin, it's like a synthetic analog of vasopressin, which is what our brain naturally secretes to tell the kidneys, hey, please reabsorb water. Right? If your brain's not making enough of it, then you're low on this. So if you give someone an analog of it, then they'll get better because they're just missing the signal from their brain to tell the kidneys to do that.
But
Whereas if their kidneys, yeah, exactly, it didn't get better because their kidneys are the ones that are at fault. It's not the brain. The brain's doing its job secreting this vasopressin, but the kidneys aren't responding to it, which is actually why I think they changed the name of nephrogenic diabetes insipidus, actually. They call it like arginine vasopressin resistant diabetes insipidus.
Yeah, that sounds familiar, yeah.
Yeah, versus like arginine vasopressin deficiency, but it's kind of like a semantics thing. So in this case, right, what would be the treatment for the patient? Should we give them DDAVP if they didn't get better with DDAVP? No, we shouldn't, because it clearly showed it doesn't work.
Yeah.
Yeah, the answer is amiloride.
So amiloride works on the ENaC or the collecting duct somewhere? I got it right. I just don't know why. Hang on. So where is the answer? Here we go. Patients who cannot stop lithium should be treated with salt restriction and selected diuretics. Amiloride blocks sodium channels in the collecting ducts to prevent lithium's cellular entry, while thiazides combined with sodium restriction promote a mild hypovolemia that acts to increase proximal sodium and water reabsorption. However, serum lithium levels increase with both options and require close monitoring. Yeah, like it's like one of those things where it's like we know what's going on and we're attendings now, so it's like we don't know the nitty-gritty details anymore. Like we know what the right answer is, but it's like unless your patient is like a nephrologist and they're pimping you on how does this medicine work, like you probably don't remember this kind of stuff off the top of your head. So a lot of people in the comments kept glazing us. They were like, wow, I can't believe you remember all of this. We're like, no, We do not remember
Secret
all of this.
we don't remember all of this. 40-year-old man comes with history of end-stage renal disease. Comes to the office, my office, for routine follow-up. He's been on chronic hemodialysis for the last 3 years, so quite a long time. Patient's parathyroid hormone and alkaline phosphatase levels have increased progressively, despite efforts to maintain normal serum phosphorus with phosphate binders. Okay, there's a lot to unpack here, but basically part of what happens is that as you have end-stage renal disease, if your kidneys don't work at all anymore and you need dialysis to take the job of the kidneys, you have issues with regulating your calcium and your phosphate, right? One of the reasons is because kidneys dump phosphate. And there's also signaling involved with the kidneys on how your body secretes or reabsorbs phosphate and calcium from your bones. And that's where parathyroid hormone comes in. Alkaline phosphatase is a enzyme that is supposed to help break down bone potentially, right? So the levels can be elevated because if your levels of calcium or phosphate are high or low and need to be adjusted, then your body normally is supposed to break down or build up bone to either increase or decrease the level of these respectively. And if things don't work out well because the kidneys aren't working, then it can slowly after years go out of whack, and that can cause problems. So we got a set of blood tests here to look at these levels, right? Creatinine super high because this patient has end-stage renal disease, their kidneys don't work. Calcium looks fairly okay. Albumin is 3.4, so just a smidge low, but really not that low. But the alkaline phosphatase is super high, 320.
Phosphorus is high.
5.1.
And then parathyroid is
PTH is definitely high.
Oh,
right there. 10 to 65.
Definitely high.
It's like 10 times higher.
Oh,
and then vitamin D. Yeah, it's normal. All right. Adding cinacalcet, which is the phosphate binder to this patient's regimen would most likely contribute to which of the following? Oh gosh. Okay.
Jesus Christ. Okay.
All right, let's see if we can like test take our way into this. Because I also don't know 100%. Like I could probably feel which ones sound most reasonable, but I don't know 100%. You'd have to look this up in like a database to see how patients actually respond from like a nation or international wide level. And I don't have that ability in my brain, so I can't tell that off the top of my head. But let's see here. A, decreased need for parathyroidectomy. I think that's possible, right?
Yeah. Okay, cinacalcet is a calcium mimetic, right? So it's like calcium, right? Because the whole point is you're trying to make the parathyroid shut up, because right now the parathyroid is secreting so much PTH because it's trying to trash phosphorus and it's trying to resorb from calcium from bone. So if you give cinacalcet, the cinacalcet exists as a calcium mimetic in the blood, and the parathyroid is like, oh, okay, there's enough calcium here, I'm fine, and it'll calm down. So I think A is valid, yes. What is osteitis fibrosis cystica?
Osteitis fibrosis cystica, it's when because your alk phos is so elevated, right, and the PTH is so high, telling the bones to break down because it's thinking, oh, calcium's so low or phosphate's too high, then it causes like small cysts to form in your bones because you're breaking down the structure.
Ew.
That's normally supposed to exist. Yeah, that's what I think. I mean, the name implies that.
Okay. Wait, but so basically this would be no, right? Because you're adding cinacalcet to prevent this from happening.
Right, exactly.
Okay.
Exactly. So I think it's not B. Overall survival, though, is a little tough, and especially because like when you get into like very big, vague, like mortality survival metrics, it like things don't usually do that. They're not like powerful enough to do so, right? And I guess when you think about like, can this medicine that helps with calming the parathyroid hormone down, can it actually make them live longer?
But what if it does?
I find a hard time to justify that. I know, right? That's the thing.
Like,
C can always be possible.
Like these mortality benefit questions, right? Either it is mortality benefit or it's not mortality benefit.
Right, exactly.
Like it's either like ding ding ding, this is the correct answer, or like ding ding ding, it's obviously not the correct answer. Nobody would ever say it prolongs overall survival. Like
I'm gonna guess
nasty.
No, but
yeah,
totally be it. Yeah.
I mean, it's valid. I think A probably is the strongest one so far.
Yeah, because it's definitely not D, because it doesn't, the calcium doesn't really interact with cholesterol plaques necessarily. I mean, I guess there are calcified cholesterol plaques, but I don't expect it to impact cardiovascular events.
Unless it does.
Unless it does.
Unless it does.
It's all the above. And then symptomatic hypercalcemia. I guess if you're calming down the parathyroid.
But it's a calcium analog, so it wouldn't.
Right.
Unless it does.
Also does.
Oh, this is so bad. I'm gonna say C and D either both have to be true or both not true, and therefore it's A.
I like your thinking. Let's go with A. Final answer.
Oh my god, wow.
Ooh, oh my gosh, okay. We got it.
Oh, Jesus Christ. Yeah, I guess cinecalcet works the way I thought it would, right? Yeah, so you have a persistently elevated PTH, and your PTH is saying trash phosphorus, give me more calcium. So you add the calcium mimetic, and it allows the PTH to go back down because it senses that there's enough calcium in the system. And if you don't have enough calcium, then you just give them vitamin D so that they absorb more calcium instead. This is dude, only 43% of people got this correct. Wow, that was definitely a hard one. Okay, I definitely would not have gotten this had I not just randomly remembered what cinecalcet does.
Yeah. I would have to made a flashcard and be like, what is cinecalcet's mechanism, to remind myself.
36-year-old man comes to the travel clinic prior to a safari in East Africa. He has a history of intermittent asthma and he takes albuterol as needed. No allergies. Physical exam is unremarkable. He wants malaria prophylaxis. Don't worry about it. It's a tovaclone. Okay, 94%. There we go.
Nice. Study evaluates the role of MRI in assessing the potential for myocardial recovery after reperfusion. A total of 185 patients undergoing coronary bypass surgery were evaluated by MRI for delayed gadolinium enhancement and indicative of myocardial scar tissue and therefore no viability. Subsequently, the patients were followed for improvement in myocardial contractility after surgery. The following results were obtained. There is this 2x2 diagram here. So I think in this situation, this is like the sensitivity, specificity, predictive value test characteristics that you learn as part of biostats, perhaps even before medical school or during medical school, that unfortunately are still relevant for you even after you graduate from med school.
We're evaluated by MRI for delayed gadolinium enhancement. So test positive, test negative, and then no contractility is negative, and then contractility recovered is positive? Because I feel like the answer, if I set this up like a normal table, specificity should be 82 over 82 plus 3. But now I don't know if this table is set up normally. Sensitivity would be 92 over 100. Specificity should be 82 over 85. Positive predictive value should be 92 over 95. And the negative predictive value should be 82 over 90, right? But
yeah,
the disease is positive if they have no contractility recovery. That's because they have scar tissue. So even if you do surgery on them, they won't recover. So that is disease positive. And if you do surgery on them and they recover, then that's disease negative. The test is gado enhancement. If the gado enhancement is positive, that means that there is scar tissue and it's not viable. And if it's absent, that means there is no scar tissue and they should improve after surgery. Yeah, so I think this is set up correctly. So it's disease positive, disease negative, test positive, test negative. So it's 82 over 85.
True negative. Yeah, exactly. True negative over true negative is false positive.
Please do not let the only question that we get wrong be a biostats. Goddamn biostats question.
Oh my gosh. Okay.
Oh my god. Wow, 49% correct. That's crazy.
Yeah.
I mean, this is just like it's not even a definition question. It's like, one, do you remember the contingency table? But like, two, do you set it up correctly by reading the question correctly?
Yeah. Can you understand what they're trying to tell you?
Honestly, no. Actually, if I was rushing through this, I would have just assumed the table was set up correctly. So then I would have just done it normally.
We overthought it so hard on this one.
I know, right? Like, it's the fact that we were able to debate it and then the table ended up being correct anyway. Like, Jesus.